Все, все, спасибо большое. Спасибо. Hello, everybody. I would like to start our lecture. We start a little bit earlier. It's just technical problem, so we'll start a little earlier. I hope that you will see me. I hope you can see me. And if you can hear and can see me, please let me know in our conversation and chat. We can start in our time in 10 minutes, but I hope that if we start earlier, so we can finish earlier too. And let me know if you can hear me. Our topic. Today, our topic today is energy and hypersensitivity types of mechanisms. So we'll discuss the mechanism of development of allergic reactions, the ways how to diagnose it, clinical symptoms, and principles of treatment. Let me know, please, if you can hear me or if not. So let me know, please, if you can hear me, and we'll continue. Okay, so today is the third lecture from our lectures on immunology and allergy. So, and we'll discuss what is allergy, how we understand it right now, how we can put diagnosis of allergy, what are the mechanisms of development of allergic reactions, and how to solve, how to work with patients with allergy. It depends on type of reactions. So several words about where does the term allergy come from. It basically means, comes from two words, altered, altered, and altered action of reactivity, and means altered reactivity. The first time it was used by Austrian pediatrician Perkia, who worked with tuberculosis children and developed the scratch test for tuberculosis. So, hypersensitivity reactions means harmful immune responses to otherwise harmless antigens leading to tissue injury and may cause serious diseases. So basically, any allergic reactions is immune reactions, but it happened not after the first contact with allergens, the second, the third, any other, and caused serious diseases, caused some injury of own tissue. That's why we cannot actually call it a reaction. And these antigens, antigen that caused allergen, are the antigen that caused allergic reactions, such like allergen self-antigens and modified self-antigens. There are four main types of hypersensitivity reactions. Type 1, anaphylactic reactions. If we means the time of development is less than 30 minutes, and type 2 reaction or cytotoxics 5 to 12 hours. Type 3 or immune complex reaction 3 to 4 hours, and type 4 cell mediated or delayed reaction 24 to 48 and 72 hours. So you can see the short scheme of types of reactions. So if we'll see attentively, we can see that we put on the base of this classification not only time of development of reaction, but also the mechanism, the pathology of its reaction. So type 1, IgE dependent or anaphylactic reactions. The antigens of this reaction are soluble antigens. It can be dust or pollen or food or so on. The main effector mechanism is activation of mast cells. Immune complex, we'll talk right now about this, about types of reactions, and example of it are examples allergic rhinitis, asthma, and of course angioedema and anaphylactic shock. Type 2, cytotoxic reaction. There are two mechanisms of cell toxicity, cell or matrix associated antigen, and so antigens are most likely cell surface receptors and cell associated antigens, and the main mechanism is complement Fc receptor cells, phagocytin, for example, and antibody alert sighting. The mechanism of development deals with the affected of cell membrane by immune complex with complement, and the example can be some drug allergens, chronic urticaria, and some autoimmune and anemia or thrombocytopenia. Type 3 reactions, so antigens are soluble antigen, and effector mechanism deals with the immune complexes that consist of antigen, antibody, and some components of complement. They fixed on some cells, destroy they're not mast cells but blood cells, and blood vessel cells destroyed and caused destroying of vessels. So the three type 1, 2, and 3 reactions deals with the antibodies. So I would like to talk and explain the mechanism of different types of reaction. I think it is important to know how the disease development, to understand how to help patient with it. And I truly believe that without understanding mechanism, we cannot be a doctor. So type 1, IgE-mediated reaction to exogenic antigens. So what we have, every immune, every allergic reaction has 3 stages in its development. So, and every immune allergic reaction starts from immune stage, and basically immune stage means what happened between the first and every other contact with allergen. So what we have at the beginning, we have antigens, soluble antigens that meet with immune system, and because of genetic predisposition and prevalence of T helpers type 2, at the end, at the response to it, we have production of IgE instead, Ig, M and G. So I would like to show that what is IgE, immune globulin E. So it consists of variable and constant region. Constant region fixed on mast cell membrane, and variable region contact with allergens. So every Ig molecule contact with the 2 molecules of allergens. So this complex, allergens, 2 allergens, and Ig molecule fixed on mast cells membrane. And we have production of Ig, as I said, in response to contact with allergen. So that's why we say that allergy is just independent reaction, because every time, every other time after this stage, allergen contact with immune system, we already get IgE specific to this antigen that fix on mast cell membrane. So every contact with allergen, every time immune system contact with allergen, Ig antibody that produced in response to it and coat mast cells, and every other time immune system contact with the antigen allergen the same specificity. The cell undergoes this complex of IgE and allergen that fix on mast cell and basophils, destroyed its membrane, and it caused the it caused that release mediators like histamine, leukotrienes that appears in granules of mast cell. So you can see resting mast cell and activated mast cell. Activated mast cell activated by immune complex IgE with allergen. Yes. So what have we have mast cells that after attacked by immune complex, it's destroyed with the releasing of a lot of granules of biological active substances. And the releasing of these substances we call phytochemical stage of immune reaction, of allergic reactions. So, and we know that these biological substances can affect different tissues and organs through their receptors. The symptom that we get, we call the clinical stage of immune reaction. So you can see that activation of histamine receptors in gastrointestinal tract, increased fluid secretion, increased peristalsis, and cause expulsion of gastrointestinal tract contents like diarrhea, vomiting, affected of um, effects of airways by mediators from mast cells cause decreased decrease their diameter and decrease mucous secretion. So we have congestion and blockage of airways. And in clinic we can see wheezing, coughing, swelling and mucous secretion in nasal passages. And effect on blood vessels in histamine, increased blood flow and increased permeability. So it causes increased fluid in tissue, causes increased flow in lymph and lymph nodes, increased cells and protein in tissue that how edema develop. So, as I said, there are some biological active substances that are released from mast cells. There you can see, and as I said, they affected target cells and caused some clinical symptoms. So, enzymes like hemase, tryptase, cathepsin remodel connective tissue matrix. And that's a toxic mediator like histamine and heparin. They increase vascular permeability, cause smooth muscle construction. Then cytokines that release from mast cells like interleukin 4 13 stimulate and amplify T helper type 2 cells response, and that basically means electric response. Interleukin 3 5 promote eosinophil production and activation, and tumor necrosis factor alpha promotes inflammation and stimulates cytokine production by many cell types. Then lipid mediators like leukotriene CD4, C4, D4A4 cause smooth muscle contraction with an increased vascular permeability and stimulate mucous secretion. So that is what biological effects that we can see from mediators released from mast cells. And as I said one more time, note you that there are three phases in allergic reactions of immediately reactions. The first one, immune stage, that means production of specific IgE antibodies that fix on mast cell membranes, but a chemical that means releasing of biological active substances that we just discussed from mast cell destroyed by immune complex of IgE antibody and allergens, and type 3 clinical, that is the what biological effect has the mediators released from mast cells. So in clinical have symptoms: peripheral vasodilatation, vascular permeability, edema, bronchospasm, cardiac arrhythmia, smooth muscle contraction. That is, you can see edema of larynx. That is again is edema. Here we can see again normal larynx and laryngeal edema. So what I would like to mention that what we mean when we say genetic predisposition to allergy. It means that from very beginning, particular person has this balance of T helpers type 1 and type 2. And as you remember from our lessons and lectures probably, T helper CD4 cell is the key cell in immune response. So, and T helper type 1 responds to antigens except allergens, and T helpers type 2 responds to allergens, and allergen activate T helper type 2 immune response with the production of some cytokine that activate production of IgE, interleukin 3 and 4, for example. So, but you need to remember that any genetic predisposition can be realized in case of environmental factors altogether can cause reaction. So, in case of genetic predisposition and positive environmental factors, we so I mean that a person with genetic susceptibility, like disbalance of type of T helpers, yes, that we just say, but without environmental factors, will not be will not have allergic disorders, and instead patients with a genetic susceptibility or without it, with some environmental factors triggers, can be atopic, like conjunctivitis, rhinitis, eczema, and so on. And that is the real picture that show you how the main allergens look like. So weak allergen, as we said, is the antigen that causes allergic reactions. And there are different types of allergy. We can divide it in internal and external, or exogenous and allergens. And allergen that basically some own structures in tissue that the immune system recognizes and is foreign and produced antibody against it. So basically auto antibodies. autoantigens. The rest we can call external or exam allergens. We also can divide it on infection and non-infections. We can put virus, bacteria, and helminths in the group of infections and the rest on non-infection allergen. So you can see here the mite, so that is environmental household allergen, mite, mites, and home dust. The next group, pollen. Pollen, allergy to pollen always deals with the seasonal pollution. Yes, that is the most frequent common bug that can cause allergy. I mean that it's supposed to be a lot of this grass or plant, and it's supposed to pollen with the wind, so there's supposed to be some condition that uh, make this grass or plant specific allergen. And about that we said about infection and allergens like helminths, yes, ascarides, reserves, all of them can cause actually allergy, but most of the time they cause eosinophilia that exclude allergy. Helminth infection induced edema. So the next group of allergen is food allergens. As statistics says, in young children, 90% of reactions caused by milk, eggs, peanut, wheat, and in adults, 85% of reaction caused by peanut, fish, shellfish. So the most common allergies still, food allergy, are milk, eggs, and peanuts. There are some signs of increasing incidence of allergy to exotic foods such as kiwi, papaya, sesame, and rape seeds, poppy seeds. But still remember that as soon as allergy is a reaction not to the first contact of allergen, so that it developed patients and persons with a genetic predisposition in very often frequent contact with some food, so this food can become the allergen. So we also have so-called cross-reacting allergen that basically mean that some structure of allergen looks like the same from at other allergen, so they can cause the reaction. Or another sign like pollen of apple can a person can be allergic to pollen of apple trees and to apple and stone fruits, apricots, and so on. So cold cross reaction we can have the same reaction for the same plants like potato, tomato. They are from one family, so they can have cross-reacting allergens, different nuts, and so on. Eosinophils and basophilic cells in secretion. As so, I would like to, as one of example of type 1 reaction, asthma, allergic asthma, atopic asthma is one of the classical example of type 1 reaction. So I would just like to note it in some tables and pictures. So as you can see, antigen effect immune system, we have production of Ig antibodies in response that are fixed on mast cells, and every contact, another contact with allergen, caused development or formation of complex Ig antibody and one molecule of Ig antibodies, 2 molecules of antigens. This complex destroyed mast cell membrane, and we have releasing of mediator like histamine, prostaglandins, and leukotrienes. They cause mucosal secretion, vasodilatation, bronchoconstriction, vascular leakage, and leukocyte adhesion. And that is what, and there are, they activate also the production of cytokines, like interleukin 4, 13, interleukin 5, that caused continuation of this process. And because cytokines, because interleukin 4, 13, and 10 actually caused IgE production, eosinophil product, hemataxis, and leukocyte adhesion. And at the end of it, we have tissue injury and earlier, one more time about type 1 reaction. Early phase reaction is degranulation of mast cell membranes, releasing of histamine and proteases, and it occurs within minutes of allergen explosion, and it caused, and late phase reaction actually occurs 3 to 12 hours post allergen explosion and caused by action of the first line active substitute like histamine. So as a result of this reaction, as we discussed pathology, we have symptoms of early fast reactions, congestion, rhinorrhea, sneezing, and of last phase reaction, congestion, rhinorrhea, and sneezing. So basically, the symptoms of last phase reaction caused by leukotrienes. So then, and one more time, I would like to mention that the mediators, I would like to put your attention on mediator and what effect it caused in clinical. So histamine and heparin increase vascular permeability, smooth muscle contraction. Primary factor that we have that released right after degranulation of mast cell. Serotonin, increased vascular permeability, smooth muscle construction. Then eosinophil hematotic factor, caused eosinophil hemataxis and neutrophil hematotic factor, neutrophil hemataxis. Then primary mediator like proteases cause bronchial mucosal secretion, degradation of blood vessel basement membrane, and generation of complement spleen products. The secondary mediator appeared under the action of primary mediator. They are platelet activating factor, It causes platelet aggregation and degranulation. Leukotrienes, slow reactive substance of anaphylaxis, caused increased vascular permeability, construction of pulmonary smooth muscles. Then prostaglandins cause vasodilatation, construction of pulmonary smooth muscle, and platelet aggregation. Then cytokines interleukin 1, 2, 3, 4, and 5, they all affect the systemic anaphylactic reaction, increased expression of CMA and on granular endothelial cells, and some other effects. So, what, how will, so that is the first type of reaction. Our actually task is to put diagnosis and to solve the problem to treat this patient. So we'll start therapy with trying to find causative allergen. We start from determine general IgE level in serum, and after we found out it is positive, we can find out causative allergen, irritants or temperature extremes of food. So diagnostic test for type 1 hypersensitivity commonly accessed by skin testing. Small amount of potential allergen are introduced at specific skin sites by intradermal injection or by drawing. So it can be scratch, it can be prick test or scarification. The idea is to find out causative allergen in liver. It's pretty safety procedure, and now you can see here on this picture positive skin test on different allergen. So we make it with a solution of allergen, and that is the easiest way to find out causative allergen, so we can exclude it. After we after we found the causative allergen, we can suggest patient different kind of therapy. There are immune therapy will include allergen-specific immune therapy. The idea of this therapy basically means the production of IgG4 blocking antibodies that compete with IgE for allergen, but the reason between them that the complex with this antibody doesn't destroy mast cell membrane, so we don't have development of clinical symptoms. It's also switch the balance for type helper T helper 1 cells, and that is the idea of it comes from here also, and the effect is pretty good, but we need to follow some condition to expect effect. So the next group, IgE inhibitors, recombinant monoclonal antibody agents, omalizumab, that block IgE antibodies. Then prevention or reserval of T helper type TH2 expression, inhibitors of the T helper 2 cytokines, treatment with soluble recombinant interleukin 4 receptor. Then we have a great group of anti-mediatory drugs, antihistamines, first generation, like chlorpheniramine, diphenhydramine, hydrochloride, triptolidine, so and some others. So positive and negative of it. So the positive side effects: fatigue, dizziness, and sedation due to peripheral anticholinergic effect and non-specific block of H1 receptors. And these side effects sometimes can be used for especially sedation. Then second generation non-sedative antihistamine, they actually the difference between the second and the first generation of H1 blockers is absent or present of sedative effect and duration of action. The primary objective of antihistamine research over the past about 30 years was centered on development new drugs with high selectivity for H1 receptors and making disobrocin as action. So the idea was to reduce the ability to penetrate the central nervous system and decrease affinity for central histamine receptor. Second generation antihistamine are cetirizine hydrochloride, loratadine, fexofenadine, avastin, hydrochloride, disloratadine, terfenadine, levothyroxine. I don't mention great names, so I hope we'll can discuss this in our classes. We also have topical antihistamines like celestine, levetiracetam, olopatadine, ketotifen, and topical and system corticosteroid. Topicals like scripts and inhalers, beclomethasone, budesonide, diazolide, fluticasone, mometazone, and systemic corticosteroid that we use as anti-mediatory drug. So H1 blockers, as you understand, block H1 receptors and block the last stage. And steroids, systemic steroid, block production of antibodies, stabilize mast cell membrane. So basically, they have anti-inflammatory effect and they block all three stages of allergic reactions. We also use some topical and systemic immune suppressive drugs, anti-inflammatory, again, basically prevention of T cell activation like anti-CD4, cyclosporin 8, methotrexate, azathioprine, mycophenolate, amoxicillin, cyclosporin, and so on. The next group of anti-allergic drugs is mast cell stabilizer. We have some of them: sodium formaldehyde, methotrexate sodium, ketotifen, oxyphenidine. And we have also monoclonal antibodies in the therapy of allergic and inflammatory diseases. Yes, here we see cell surface markers CD4, CD45, CD23, adhesion molecule, transcription factors, cytokine, interleukin 5, like mepolizumab, TNF5, infliximab, and antibody idea malizumab, as we say. So the idea of these drugs is biological drugs, either to block factors that have the key role in the development of reactions more specific than another drug. The next rule that we use uh, in treatment and of electric reaction are leukotriene modifiers. There are two rules. Leukotriene modifiers, they include single leukotriene 1 receptor antagonist and 5-lipoxygenase inhibitors. The first group are montelukast, pramlukast, firlukast, and the second zeoliton. All of them are already we have as a drug. So cytokines and cytokine agonist, receptor antagonist interleukin 4, TNF-alpha, anti-inflammatory cytokine interleukin 10 and 18. So at the end, I would like to say that type 1 reaction has 3 stages of development, and depend of which we can affect. We can use different substances to affect the third, the second, the first stage. So the success of our treatment will depend on what target will match. Type 2 hypersensitivity, antibody-mediated hypersensitivity to cell surface antigens or components of extracellular matrix. So IgE-mediated drug allergen, anti-self antibodies, blind red blood cells. So what we have in clinic, we have the same stages as the type 1 reactions. So the first immune stage is the production of specific antibodies. In this case, it will be IgM and G that make complex with the allergen that can be the drug or something. And this complex destroy blood cell membrane. And there are another way, it's complement activation and intravascular hemolysis. So these complexes bind red blood cells or thrombocytes, because of it we had in clinic thrombocytopenia or anemia. So it can be also disease mediated by auto. So basically we have the production of antibodies to all T cell structures. As an example, is myasthenia gravis. So what we can see, acetyl receptors. In normal, it depends on neural inputs, so we can move. And in myasthenia gravis, because of block acetylcholine receptors, and because its immune system recognizes it as a foreign antigen, we stop this process, stop neural impulse, and in clinic we have no muscle contraction. So I can see that somebody appear in chat. So I'm going to see everybody. Yes. So examples of type 2. Examples of type 2 reactions. Transfusion reaction. Cells from an uncompatible donor react to the host's antibody. Then erythroblastoses CT, there is an antigenic difference between the mothers and the fetus, and antibodies IgG cross the placentas and cause destruction of fetal red cells. Then autoimmune hemolytic anemia, we discussed already, granulocytosis, thrombocytopenia. Individuals process antibodies to their own blood cells and are then destroyed. And drug reaction, antibodies are produced that react to the drug. The examples of type 2 hypersensitivity. mm, Graves' disease, myasthenia gravis, insulin-resistant diabetes, hyperglycemia. So, uh, in Graves' disease, antigens is the thyroid-stimulating hormone receptor. Immune system recognizes it as a foreign antigen. In most cases, it deals with the absence of connection between immune system and these organs during pregnancy. So, in adult, immune system can recognize these antigens as a foreign and produce antibody or antibody in response. So, Graves' disease antigen is thyroid-stimulating hormone receptors, and as a result, hyperthyroidism. Myasthenia gravis. Acetylcholine receptor is an antigen, autoantigen, and in clinic we have progressive weakness. Insulin receptor, in case of type 1 diabetes, immune system recognizes insulin receptor as a foreign, and we clinical have ketoacidosis, type 2 diabetes, and hyperglycemia, insulin receptor agonist, and in clinic hyperglycemia. So, Goodpasture syndrome, disease is mediated by autoantibodies. You can see that this complex activate complement and FC fragment of receptor with monocytes and neutrophils. Um, so the next type is type 3 or immune complex disease with soluble antigens. So compare with the first two types of reaction, immune complex of allergen and antibody and complement, not fixed on particular cells but circulate in the blood and cause that phenomenon like serum sickness, Arthur's reaction. So immune complex diseases involve reaction against soluble antigens circulating in the serum, involve IgG antibodies and C3, C4 components of complement. Every time an antibody binds an antigen, an immune complex is formed. Under normal conditions, complexes are bound by complement to red blood cells and then eliminated by phagocytes. In type 3 hypersensitivity, immune complexes are not cleared out and then became deposits in tissue. In type 3 hypersensitivity, the antibody involved is primary IgG. The immune complexes activates complement, as I said, 3 and 4, leading to degranulation of mast cell. The production of mast cell degranulation causes blood vessels to become more permeable, and this allows the immune complex to be deposited in the walls of the blood vessels. The neutrophils release lysosomal enzymes into the area, causing further damage of the vessel wall. A normal immune complex fixed complement and are cleared by mononuclear phagocyte system. In case of immune complex disorder, small complex is antigenic cells do not fix complement in solution but deposit along blood vessels or basement membranes. Complement may be fixed to tissue deposit and the blood vessel looks like this. So we have in clinic we have immune complexes that circulate in blood pretty pretty large immune complexes. And some diseases can be a classical example of type 3 mechanism, like serum signals, post-streptococcal neuronephritis, lupus erythematosus, systemic lupus erythematosus, and pharma-lung interference reaction. Diseases with type 3 mechanism. Serum sickness, as you see, there are three stages again. Yeah, the immune stages for serum injection, and um, this incubation basically means immune stage, and it starts from clinical stage in a couple of days or weeks. Then there's tooth reaction, the same you can see. Locally injected antigen in immune individual with IgG antibody, then local immune complex formation with CD3 activation of fetal mast cell through the degranulation, and the regulation of mast cell caused local inflammation, increased fluid and protein release, phagocytosis, and blood vessel occlusion. And the last mechanism of development is our type 4 reaction, T cell mediated or deleted hypersensitivity reactions. So immune reactants, instead antibodies, we have T helpers type 1, 2. Antigen can be cell-associated antigen, soluble antigens actually. And effector mechanism is macrophage activation, ID production, eosinophil activation, and cytotoxicity. So delete, as you can see, the idea of this reaction. We have this mechanism, antigens activate lymphocytes that produce some biological active substances. So we have the same classical, like tuberculin test in the classical example. Let's see the examples. The only type that is not antibody mediated. Contact hypersensitivity, tuberculin type hypersensitivity, granulomatosis hypersensitivity like lepra, tuberculosis, Crohn's disease, contact hypersensitivity, poison ivy, poison oak. Then it is called delay because its onset may vary. Occurs hours to the length of the delay varies from 72 hours in contact hypersensitivity and 21, 24, 8 days in granulomatosis hypersensitivity. Contact hypersensitivity, the contact dermatitis, as you see, is contact sensitizing agent, in which all physical urticaria or chemical urticaria and so on. Contact sensitizing agents penetrate the skin and bind the cell to cell protein. They're taken by lung membrane cells. These cells present cell peptides patterned with the contact sensitized agent to help us type 1 cells. We secrete interferon, gamma, and other cytokines. Activated keratinocytes secrete cytokines such as interleukin 1 and tumor growth factor alpha and chemokines. And the purpose of keratinocytes anti-help of one cells activate macrophages to secrete data on inflammation. Here you can see how it looks like urticaria, contact urticaria, or contact dermatitis. And at the end, the example of type 4 reactions. We can see contact dermatitis, the response to poison of, for example, classic type S, small molecule sect at heptans, and complex with skin proteins to be taken by antigen-presented cells and presented to T helper type 1 cells. During secondary exposure, T helper 1 memory cells become activated to cause DTH. Here the tuberculosis skin the same. We have reaction with allergen activate lymphocytes, and they produce antibody that, and we can see reaction in 72 hours. And poison-mediated contact hypersensitivity reaction. It's not allergy, as you can see. And how we can find out the positive allergen? Allergen is patch testing used to identify it. Skin doctors always substances to which the client is potentially allergic. And contact with specific allergen result in the late reaction they develop at 84-96 hours. That's why we actually use not just like we did in type 1 reaction in 15-20 minutes. We use this great paper to estimate it in a couple of days. So that is all I would like to tell you. I was glad to see everybody, and I hope that we'll discuss this topic in our classes. Tomorrow I have classes with them. I'm sorry. Tomorrow I have classes with them. Group 151. I have classes on immunity. And tomorrow I have classes in 151A group. I'll wait you tomorrow at Simashka Clinic. We get lessons in hematological department. We have a class here. I suggest you to come at about 10 o'clock, your time, 10 o'clock, and give me a call, please, so I will know that you're already waiting for me, and we'll get classes. You need to put on uniform white coats, hats, and another shoes, and looks like a doctor, not like a builder. So I wish you good luck and have a good evening. Goodbye. Thank you for your attention. Did you hear me?